Lacher, and welcome to Medical Grand Rounds. We're so excited to be back to kick off the fall season. And as usual, we'll go ahead and get started with some reminders and a few logistics, followed by introduction of today's speaker. So please be sure to also join us next week. We'll be hearing the talk Angina with Non-Obstructive Coronary Arteries, sometimes known as ANOCA, given by Dr. Rick Sohn. Grand Rounds is a collaboration between Providence Portland and Providence St. Vincent Medical Centers. We are often here live in the room, as we are today in Souther Auditorium at St. Vincent's, and that's at 8 a.m. on Tuesdays. We are sometimes live at Providence Portland, particularly when we have guest lectureships, and those occur at noon on the same day, Tuesdays at Providence Portland. Available to watch live virtual through the Teams platform. And you can earn CME credit by being live in the room, watching virtual live, or by watching a recording of the event. And just as a reminder, the invite you get for Grand Rounds each week will let you know where and when we're meeting, and also has the link to the recording. I'll be monitoring the Q&A throughout today's session, so please go ahead and post any comments or any questions, and I will mostly hold those to ask at the end as time permits. And now to introduce today's speaker. We are joined by Dr. Abby Fry, a clinical pharmacy specialist with Providence Medical Group. Dr. Fry earned her BA in chemistry from Central College in Pella, Iowa, before moving to the Pacific Northwest for pharmacy school at the University of Washington. After pharmacy school, she completed 2 years of residency with Providence Health and Services, including a PGY2 year in primary care with Providence Medical Group. And currently, Abby is a clinical pharmacy specialist where she provides collaborative management for patients with diabetes, hypertension, osteoporosis, and other chronic conditions. She also serves as a drug information resource for other providers and is very involved with the education of internal medicine residents, pharmacy residents, and pharmacy students. I feel super fortunate to work alongside Dr. Fry nearly daily, and it is such a delight to have her back again today as an outstanding educator.
All right. Thank you, Laura. Thanks for that nice introduction, and especially thank you for inviting me back for another Grand Rounds. Happy to be here to kick off this year's series. Happy to see lots of friendly faces here in the room, and thank you to those of you joining online. So today I'm back to present another Hot Topics in Pharmacotherapy, kind of my annual update, so to speak. I have no disclosures. And my objectives are, as usual for these sort of annual updates, my goals are to evaluate recent studies that provide pertinent information about medications, to help identify emerging safety concerns with commonly prescribed drugs, and to discuss new evidence that clarifies the roles of established therapies. Today's topics include a review and summary of the recently published 2025 high blood pressure guideline, a look at several GLP-1 receptor agonist updates, a look at a couple of studies that help clarify and solidify the role of anaronone for HFpEF and chronic kidney disease, and finally, a look at 2 new studies regarding the use of the reduced dose versus the full dose of a DOAC for extended treatment of VTE. So we'll start off with the 2025 high blood pressure guideline. Anybody that works with me or knows me knows I love talking about the treatment of a high blood pressure. And so I was really pleased when this was published just less than a month ago, so it would be in time for me to talk about. So I want to start off by looking at some things that haven't changed in this guideline. So this is, of course, the update from the 2017 blood pressure guideline. And there are several things that have been just solidified and renewed in this guideline. The classification of high blood pressure hasn't changed. So normal is still less than 120/80, with hypertension starting at 130. So stage 1 hypertension is folks with blood pressure between 130 to 139 and 80/89 at time of diagnosis, with stage 2 hypertension 140/90 or greater. The guideline highlights and renews the importance of out-of-office blood pressure monitoring. So this includes home blood pressure monitoring and 24-hour ambulatory blood pressure monitoring. You certainly know from clinical practice that this out-of-office blood pressure monitoring, when combined with other interventions such as frequent follow-ups, the use of evidence-based treatment algorithms, can really provide a lot of valuable information, and not only valuable information, but contribute to improved office blood pressure control rates. The guideline really highlights the importance when we're using home blood pressure monitoring that it needs to be accurate. And we all know that blood pressure monitoring is very technique dependent. So it's important when we use home blood pressure monitoring to make sure patients have a validated cuff that's accurate, that fits them well, and that they know how to use it. So education on that is one of the roles that a multidisciplinary team can take on. So multidisciplinary team-based care is effective for the treatment of hypertension. This includes team members, of course, the physician, specialists when indicated, nurses, medical assistants, clinical pharmacists, dietitians, social workers, and community health workers can take on a lot of the work and work together to lower blood pressure. Some of the team members can take on an important piece of the treatment plan, which is considering and addressing social determinants of health, things like economic stability, a patient's education, housing and living conditions, their neighborhood environment, all those other factors that affect adherence and affect treatment success. So none of these are new concepts, but these have all been kind of renewed and solidified in the current guideline. As far as treatment, a couple other things that are the same as previous is, of course, the importance of lifestyle modifications throughout the continuum of high blood pressure, and the recommendation to initiate both pharmacologic and non-pharmacologic therapy for folks with stage 2 hypertension at diagnosis. A new recommendation, or that's really, I think, called out a lot stronger in this guideline, is that ideally initial therapy will include single pill combination therapy for folks with stage 2 hypertension. I'll come back to talk about this a little bit more on future slides. For individuals with stage 1 hypertension, the guideline recommends stratifying them by risk to help guide treatment initiation. So folks with cardiovascular disease, or those at a particularly high risk for cardiovascular disease, which includes chronic kidney disease, diabetes, as well as a 10-year prevent CVD risk score greater than 7.5%. For those high-risk individuals, initiation of medication therapy alongside lifestyle modifications is recommended at the time of diagnosis. Whereas for our lowest risk individuals, those with a 10-year prevent cardiovascular disease risk score of less than 7.5%, we should start with just lifestyle modifications and then reassess after 3 to 6 months. If at that time blood pressure remains above greater than 130/80, that's when we should initiate medication therapy, along with kind of renewed focus on those lifestyle modifications. And then, of course, we should reassess every 2 to 4 weeks. I think this is a given, but I think an important thing to call out, because we know anything we can do to reduce therapeutic inertia and continue to follow up and make changes and get people to the appropriate intensity of treatment is really an important piece of treating hypertension. So I mentioned the PREVENT calculator a couple times. This is the first national guideline that uses the PREVENT calculator or PREVENT equations. These equations or calculator was actually published a couple of years ago in 2023. And I think I was excited to learn about it then, but there was this kind of like, I don't know how to use that at that point. But this is now included in these guidelines, so I wanted to highlight this. So the PREVENT equations are an update from the pooled cohort equations, or what we commonly think of as our ASCVD risk calculator. However, these equations were derived from a larger, more contemporary, and more diverse U.S. data set, and provides a more accurate assessment of 10-year ASCVD risk across sex and all race and ethnicity groups. And it particularly improves the accuracy of calculating ASCVD risk in our Black population as compared to the current equations. It's also validated for a slightly age group. So it's validated for adults aged 30 to 79 as compared to the current equation start at 40. So we can risk assess at a slightly lower age, which I think could be helpful. And it provides both a 10-year and a 30-year risk calculation. And then finally, it incorporates some additional predictors. This includes measures of kidney function, so the urinary albumin-creatinine ratio, as well as the eGFR, as well as a measure of glycemic control and the A1C. And then it gets at kind of the social determinants of health with the use of a zip code that's used to estimate the social deprivation index. What it doesn't include is race, because there is kind of a growing acknowledgement that race is not a biologic factor and is more of a social construct, but it does include, again, those social determinants of health in a different way. Along those same lines, the 2025 blood pressure guideline has eliminated the race-based recommendations that we saw in previous iterations of these guidelines. Race-specific recommendations first showed up in 2014 and were reiterated in the 2017 guidelines. As we all can remember, this called for different initial monotherapy. So specifically for Black individuals, recommended calcium channel blockers or thiazides preferentially, whereas for non-Black individuals, recommended calcium channel blockers, thiazides, or ACE inhibitors. And several studies showed that despite adherence to these race-specific monotherapy recommendations, blood pressure control rates did not improve and the racial disparities persisted. So in this current guideline, I was really pleased to see that it's a more race-conscious approach as opposed to a race-specific recommendation. So the new guidelines call for considering all antihypertensive options for blood pressure control in Black patients with a greater focus on achieving the appropriate intensity of treatment, using early combination therapy, and really addressing that individual in front of you, addressing diet, lifestyle, and social determinants of health as needed in a culturally competent way. Okay, moving on to goals. I think the goals that were recommended in the 2017 guidelines were some of the most controversial things about it. That was the first time we saw this more intensive goal, or kind of a renewed focus on this more intensive goal of less than 130/80 to reduce the risk of cardiovascular disease and all-cause mortality. That goal has been reiterated here. So it calls for at least less than 130/80 with this kind of italicized encouragement, very soft. I feel like they're trying to move people in that direction without knowing that it would probably not be accepted if they've made a more hard recommendation for less than 120/80, but with encouragement to achieve less than 120/80 if you can in an individual that you're treating in a safe way. So there's growing evidence. There are several studies that confirm that this more intensive treatment goal of less than 130/80 is associated with a reduction in cardiovascular disease, including reductions in stroke, heart failure, as well as all-cause mortality. And there's a couple of large trials, I'm thinking of the SPRINT trial, as well as a newer one that included folks with diabetes that even support that lower goal of less than 120/80. But it certainly needs to be individualized for the patient you're treating. I think some really good news that we can now tell patients is that this intensive blood pressure control of less than 130/80 has not only been associated with a reduction of cardiovascular disease and stroke and death, but also with a reduction in the risk of dementia. I personally find when I'm working with patients, that can be a really motivating for everybody to do anything we can to reduce dementia. And we know that from a couple of recent studies that have come out since the last guidelines, that intensive blood pressure control is in fact associated with a 12% to 19% reduction in dementia. Okay, I've mentioned the single pill combinations a couple of times. This is another thing that I think personally I've been talking about using single pill combinations as initial therapy for a little while now. So I was pleased and maybe felt a little validated that it's more kind of called out in the current guidelines. The reason this is recommended is that studies have shown that use of single pill combinations is associated with improved adherence and greater blood pressure lowering, even as compared to starting combination therapy with two separate drugs. So certainly starting with 2 separate drugs is an option, but we know that that one pill seems to make a difference in terms of improving adherence and reducing therapeutic inertia, therefore leading to greater blood pressure lowering. In the START study, which was published in 2023, adults with hypertension who were on single pill combinations had fewer cardiovascular events and fewer all-cause deaths as compared to those on equivalent multi-pill combination therapy. So again, that the more pills we add, the more likely patients aren't taking them, I think is my, my takeaway. And so using single pill combination when we can really does make a difference. I think it's appropriate for most, but certainly it's not appropriate for everyone. So there's certainly times where the stepped care approach, we might think about it as, start low, go slow, 1 pill at a time is appropriate. That might be the most appropriate for folks closer to goal, so the folks with stage 1 hypertension, those more frail older adults who are worried about, maybe we're more worried about hypotension, or individuals with a history of hypotension or multiple drug-associated side effects. I certainly see this in practice. Folks who have that really long intolerance list, I get a little worried about starting combination therapy. And even if I know which drug maybe caused the side effect they experience, I get worried that they're not going to be willing to take either of those drugs if they think it caused the side effect. And so one at a time to kind of preserve our drug therapy options is reasonable in those patients. But I always consider those the exceptions, whereas the majority of individuals starting with single pill combination therapy is a reasonable and recommended choice. So I briefly mentioned earlier, one of the pieces of a comprehensive treatment plan and success with blood pressure management is the use of evidence-based algorithms. Over the last few years, I've put together this one. It's a race agnostic, so this is kind of for all comers with high blood pressure as a way to leverage the available single pill combinations into starting with, one of our calcium channel blocker plus RAS inhibitor combinations that's available, increasing that if blood pressure is still elevated, moving on to adding our third first-line class, which is the thiazides, and then finally adding a spironolactone or a mineral receptor antagonist if needed for resistant hypertension. So as I just said on the previous slide, I think this is appropriate for most, but not everyone. There are certainly some drug therapy considerations. So as I said, starting with single agent might be the better option for some. For folks with a history of stroke, incipient heart failure, or calcium channel blocker intolerance, we could use one of the other single pill combinations where I could fill up a whole slide with the list of them, all those ACE inhibitors or ARB that are connected with hydrochlorothiazide. So that is certainly a reasonable option. An ARB combination would be preferred over an ACE inhibitor for Black individuals based on that lower risk of angioedema with the ARBs. And then finally, although all of those single pill combinations listed at the top there are generic, some of them land themselves on higher tiers for people's insurance. And so if a high copay with one of those is an issue, then what I have found locally with our coverage mix, the lowest cost options are amlodipine benazepril, that's consistently low cost, or lisinopril hydrochlorothiazide is consistently low cost. So I usually start with one of my preferred options, which includes amlodipine benazepril, and then kind of adjust from there if needed, if cost is the factor that's driving the inability to use it. Okay. Moving on to our next topic, GLP-1 receptor agonist updates. I will be honest, I feel like I talk about GLP-1s every day, and sometimes I feel like that makes me resist talking about them in presentation settings because I know it's not just me, right? Our patients are asking about them, they're in the news, they're all over your social media feed if you accidentally use your own phone to search for something about work related, if you're me. But I think a lot of important studies have come out in the last about year and a half since I was here. And so I think I needed to give them their due. So the first study I want to look at is the FLOW trial. This was the first GLP-1 study designed to evaluate major kidney disease events as a primary outcome in those with type 2 diabetes and CKD. It included just over 3,500 adults who had type 2 diabetes and CKD. In this case, CKD was defined as an eGFR of 50 to 75 and the urinary albumin creatinine ratio up over 300, or a lower eGFR of 25 to 50 with a more moderate urinary albumin creatinine ratio of up over 100. The mean age in this trial was 67 years, 30% were women, 66% were white, less than 5% was Black, which I wanted to call out because we know that kidney disease disproportionately affects Black and Indigenous people. And these were, as you will see with all of the studies that I go over today, were really underrepresented in this trial. So that's certainly a limitation. Nearly everybody in this trial were on RAS inhibitors, but a really low amount were on SGLT2 inhibitors. The SGLT2 inhibitors, which we know have kind of clear evidence of benefit in CKD, were not yet approved for kidney protection when this trial was started. As along with the mineralocorticoid receptor antagonist, which I'll talk about on future slides. So certainly a limitation that a pretty small percentage were on SGLT2 inhibitors. Individuals were randomized to semaglutide, 1 milligram weekly, or placebo. And the primary outcome in this case was a composite of the onset of kidney failure, at least a 50% reduction in the eGFR from baseline, or death from kidney-related or cardiovascular-related causes. The study was stopped early at a median of 3.4 years due to efficacy. And what they saw at that point was a significant reduction in the major kidney disease events, 23.2% in the placebo arm versus just 18.7% in the semaglutide arm, which works out to a number needed to treat just over 20. So pretty significant, clinically meaningful reduction. They also show, not shown here, but also shown in the trial, a significant reduction in the major adverse cardiovascular events, so the 3-point MACE outcome, which we've seen before with semaglutide, so that was not surprising, as well as a reduction in all-cause mortality. This reduction in the primary outcome was really driven by a reduction in that persistent greater than 50% reduction from baseline in eGFR, as well as the death from cardiovascular causes. This is the strongest evidence regarding GLP-1s for chronic kidney disease and type 2 diabetes to date, but it's not our only evidence. In a post-hoc analysis of the SURPASS trial, tirzepatide was also shown to significantly reduce a similar composite kidney endpoint as compared to the use of insulin. And then a couple of trials looked at some kidney outcomes in folks without diabetes. So in the SMART trial, overweight or obese individuals with albuminuria but not diabetes saw a significant reduction in albuminuria. And then in the SELECT trial, again, in folks with overweight or obesity and ASCVD, but not diabetes, they saw a significant reduction in the secondary kidney outcome. So there seems to be kind of a growing set of evidence indicating that the GLP-1 agonist provides some kidney benefit. So looking at the current KDIGO guidelines, which is mirrored as well as in the American Diabetes Association guidance, right now, GLP-1 agonists are in that kind of second tier. So our first line treatment is SGLT2 inhibitors, metformin, and RAS inhibitors. And then right now, the guidance says that GLP-1 agonists that have documented cardiovascular benefits can be added if needed based on A1C goal. I expect this new evidence to probably strengthen and change that guidance, that we should be thinking about adding GLP-1s kind of regardless of their A1C goal, like we think about with cardiovascular benefit. I think that we're going to be moving in that direction with kidney disease benefit as well. So I think we no longer are really asking if we should be using GLP-1s for kidney disease benefit, but just more need clarification on how and when to add them. Moving on to another disease state topic area. This is tirzepatide in HFpEF and obesity. This was a double-blind, randomized, placebo-controlled trial at 129 sites in 9 countries, but fairly small in terms of numbers, so 700 adults with chronic heart failure. and a preserved ejection fraction, so ejection fraction of 50% or greater, and obesity of BMI of 30 or greater. The typical patient had an age of 65 years, about half were women, again, an underrepresentation of Black individuals. And in this case, the majority were on RAS inhibitors, beta blockers, and diuretics, but a pretty small percentage were on SGLT2 inhibitors. And again, a limitation given we know the kind of strength of evidence for SGLT2 inhibitors in HFpEF. These folks are randomized to tirzepatide up to 15 milligrams a week or placebo. And the primary endpoints, there were two of them. One was a composite of adjudicated death from cardiovascular causes or a worsening heart failure event, as well as a look at patient-reported symptoms in the KCCQ CSS score. And what we saw was a significant reduction in death from cardiovascular causes or a worsening heart failure event. This was driven by a significant reduction in the risk of a worsening heart failure event. There was no difference in death from cardiovascular causes, but the numbers were quite low. So there were only 36 events in the tirzepatide arm and just 56 in the placebo arm. So really small numbers here compared to other trials like with the SGLT2 inhibitors. In terms of functional status and quality of life, we saw a significant increase in the KCCQ CSS score after a year of treatment. Just to kind of contextualize this, changes of 5 points represent clinically meaningful changes. Changes of 10 points represent moderate to large clinical changes. And scores up over 75 are considered to be kind of good to excellent health status. So we saw a significant increase in both arms, to be fair, but a greater increase and a significant difference between the tirzepatide treatment arm versus the placebo. So what can we say about GLP-1 agonists for HFpEF and obesity? So this study, I should say, adds to a prior study that looked at semaglutide in a similar patient population. That study did not look at heart outcomes, just looked at symptoms and functional status. And what we see from both of these trials is that GLP-1s clearly contribute to weight loss in this population. They contribute to a really significant improvement in quality of life, as well as functional capacity. But I think we need more information regarding the reduction in heart failure events. So I mentioned the really small numbers, so only 92 total primary endpoint events compared to like 1,000 or even 2,000 in the SGLT2 and finerenone trials. So we need some more evidence to really solidify if these are going to contribute to those harder outcomes. So looking at the most recent expert consensus regarding HFpEF treatment, we know SGLT2s are kind of first line. Most probably, I'd say, have the greatest evidence for treatment of HFpEF, with less strong recommendations for our mineralocorticoid receptor antagonists, our ARNIs, and our ARBs. GLP-1s are currently not on here, but I have a feeling they are probably going to at least get added for certain populations. So again, all of our evidence is regarding patients with obesity, and especially seem to have the pretty significant effect on functional capacity and symptoms. So our like more highly symptomatic patients with obesity, with HFpEF, I think the current evidence would certainly support that GLP-1s might benefit them. Okay, next disease state area, obstructive sleep apnea. So this study looked at tirzepatide and obstructive sleep apnea and obesity. It was actually the combination of two trials. Trial 1 enrolled individuals using CPAP, and trial 2 individuals not using CPAP. Fairly small, just under 500 adults with moderate to severe obstructive sleep apnea, defined as an AHI of 15 or greater, and obesity, but without diabetes. In kind of a combination of the two trials, the mean age was about 50 years. 30% were women, 65% white, with just 6% Black individuals. And the mean AHI was high at 50, with a mean BMI of 39. And these individuals were randomized to tirzepatide up to 10 or 15 milligrams per week or placebo. And the primary endpoint was a surrogate endpoint of a change from baseline in the AHI. And the results showed really significant reductions in AHI. Just to put this in context, some kind of expert groups have proposed a 50% improvement in AHI as clinically relevant. And again, kind of on average, these folks started with an AHI of about 50, saw reductions of 25 to 29, so around 50% reduction. And about 50% of patients who are randomized to tirzepatide achieved an AHI of less than 15, which is kind of the threshold for clinical significance for obstructive sleep apnea. However, the change in AHI has not been validated as a surrogate marker of clinically relevant endpoints. I think we need, it's kind of promising data, but we don't really know how this is going to affect other outcomes when it comes to obstructive sleep apnea, but certainly promising. Yes. Well, trial 1 included people, everybody was using a CPAP in that. In trial 2, no one was using a CPAP. So it's a mix. It's like 200 in each or so. Yeah. Um, I will say, I think obstructive sleep apnea is why kind of thinking of like, okay, I want to prescribe a GLP-1 to this person with obesity and obstructive sleep apnea might be why I get questions about most often. I say I get less questions about diabetes, but lately more questions about obstructive sleep apnea. So I apparently felt the need to write this really big on the slide, that clinical evidence and FDA approval, because tirzepatide has now been approved for the use in obesity and obstructive sleep apnea, does not equal coverage and affordability. So it's certainly not 100%, but I would say the majority of individuals do not have coverage for weight loss medications. And so if they don't have diabetes, most people are not going to have a GLP-1 covered by their insurance, even if they have severe obstructive sleep apnea. Unfortunately, even if they have HFpEF and obesity. That's not 100%. Some people do have coverage for weight loss medications, but I would say the majority do not. So it's really important. So again, I have lots of people come and say, this person has, severe obstructive sleep apnea and obesity. I want to prescribe a GLP-1. Which one's going to be covered? And unfortunately, I have to say, yeah, that would be a great choice. But we need to know if they have weight loss medication coverage first to see if it's going to be affordable, unless they can afford $500 to $1,000 a month out of pocket. And I will say, so step 1 would be having the patient ideally ask their insurance whether they cover weight loss medications. You want to ask that as opposed to whether they cover tirzepatide, because they will. Most insurances are going to cover tirzepatide, but for folks who have type 2 diabetes. So if they have weight loss medication coverage, and then if they do, then in my experience, it's going to require a prior authorization, and most insurances are limiting it to folks who meet the trial kind of inclusion criteria. So the folks that I've seen have coverage for tirzepatide for obstructive sleep apnea and obesity. They must have documentation of an AHI over 15, which we've kind of ran into as something where they have obstructive sleep apnea, but it hasn't been identified as being moderate to severe. They don't get it covered. That's not a 100% rule. Some people out there have this amazing, apparently, coverage and cover everything. But I would say more often than not, we're still lagging behind coverage, is still lagging behind this clinical evidence. Okay. I'm going to resist talking anything more about cost, but we can answer questions later if you have them. The final clinical update I want to provide regarding GLP-1 agonists is regarding oral semaglutide and cardiovascular disease. So this was the SOUL study published earlier this year, randomized, double-blind, placebo-controlled trial that included just over 9,000, just under 10,000 adults with type 2 diabetes, known cardiovascular disease, chronic kidney disease, or both. The mean age was 66 years, 30% women, really underrepresentation of Black individuals again, with an average A1C of 8%. pretty standard as compared to other cardiovascular outcomes trials. Individuals were randomized to once daily oral semaglutide, titrated up to the max available dose of 14 milligrams a day, or placebo. And the primary outcome was our usual for these trials, the 3-point MACE outcome assessed in a time to first event analysis. The duration here was a median of 4 years, and what they found was a significant reduction in the major adverse cardiovascular events in the oral semaglutide arm, with a number needed to treat of about 50, which is pretty similar to the prior trials of semaglutide, or the subcutaneous semaglutide, or liraglutide, or dulaglutide. So kind of same as compared to our other GLP-1s, subcutaneous GLP-1s that have shown a cardiovascular risk reduction. I want to call out that oral does not mean easy. So a lot of times people are like, oh, this person doesn't want to do an injection. We'll just do oral semaglutide, which is a reasonable option. I feel better about its cardiovascular data now. I should mention there was a previous cardiovascular outcomes trial for oral semaglutide, which showed it to be non-inferior but not beneficial. But that trial was small and short. And so I think that was likely why it didn't show that benefit. Whereas now that they made it kind of the appropriate length with a bigger population, similar to other cardiovascular outcomes trials, they showed this benefit. But oral doesn't mean easy. Oral semaglutide is pretty hard to take, in my opinion. It has to be taken every day on an empty stomach, at least 30 minutes before any other food, any other meds, and only with a little sip of water. People, in my opinion, have a hard enough time taking a bisphosphonate once a week. This is hard to do every day. And if you don't take it this way, it's not going to get absorbed. It's very, very poorly absorbed. So just something to think about. Certainly, I've had some success with folks who are really against an injection and are willing to adhere to this. But I think in my experience, it's easier to teach somebody a once a week, easy to use pen injection, as opposed to making sure they're adhering to this. There is some new bit on the horizon. There's a new one. I thought about how to say this and haven't decided yet. Orforglipron, I don't know. It's a new GLP-1 oral that's in the pipeline that can be administered without restrictions to food or water intake. I think if this shows kind of similar evidence as our injectable GLP-1s, it probably will be kind of a new ball game when it comes to selection. So to summarize our GLP-1s, for type 2 diabetes and CKD, subcutaneous semaglutide was associated with a significant reduction in major kidney disease events. For HFpEF and obesity, GLP-1s contribute to substantial improvements in quality of life and functional capacity. For obstructive sleep apnea and obesity, it was associated with a significant reduction in AHI, tirzepatide specifically. Oral semaglutide has now demonstrated similar cardiovascular risk reduction as several of our other subcutaneous GLP-1s. And amongst all of these trials, there were no new safety concerns. That doesn't mean no safety concerns, just no new ones. So I can't talk about GLP-1s without talking about safety and reasons we maybe wouldn't use them, because I think sometimes that gets overlooked when we see all this really positive evidence. So GLP-1s are still contraindicated in personal or family history of medullary thyroid cancer or multiple endocrine neoplasia syndrome. I will say there are some observational studies coming out that are suggesting maybe that medullary thyroid cancer risk doesn't need to be as strictly contraindicated, but I don't feel comfortable yet using them if somebody has that for personal history or family history. And we need to use caution in folks with a history of recurrent pancreatitis or a high risk for recurrent pancreatitis. GI side effects are by far the most common. They're the reason that patients stop these medications. They're typically mild, they're typically transient, but they can definitely be severe and dose limiting. And when they are severe, they can lead to other problems. So if folks are dehydrated because they are throwing up or having diarrhea, that is when I've seen them land in the hospital with AKI or even DKA. I don't think it's the drug necessarily causing it, except the drug is causing the side effect, but it's the dehydration from that. And I've had folks that frankly, don't tell me that they're sick, because I think they want so badly to stay on this medication and have it be successful, that I think it's really important that we're pretty clear about the risks and make sure they know when they should stop taking it and tell us. There's also a kind of growing appreciation of the risk of gallbladder disease with the GLP-1s. I think it's important if we're using these in type 2 diabetes and those folks are on other therapies that do have a risk of low, so insulin specifically, maybe a sulfonylurea, that if we're adding the GLP-1s, which can be very effective A1C lowering meds, even though they can't cause a low by themselves, or I feel pretty good about their safety, if they're using insulin, they're going to probably need that adjusted. And then finally, rapid weight loss can increase the risk of sarcopenia. For most patients, this doesn't seem to be a problem. They're kind of studying this and seeing and looking at this, but I think it can be a problem and something to consider in older adults or those with low baseline muscle mass or those who aren't engaging in resistance training or consuming protein. I've certainly had folks where you ask them what they're eating and they're barely eating on a GLP-1. And so I think, again, talking about the importance of getting enough nutrition and keeping those muscles strong and doing resistance training and not just looking at a number on a scale is really, really important. And just to compare these, I often get these questions. So tirzepatide is by far and away the most effective in terms of weight loss and A1C lowering, followed by subcutaneous semaglutide, kind of distantly followed by the rest. Not that the other ones don't contribute to weight loss or A1C lowering, but tirzepatide's the most effective. Tolerability-wise, dulaglutide in trials seems to be the best tolerated, maybe because it's a little less potent, but certainly a lot of significant individual variance. So if folks don't tolerate one, as long as it wasn't really severe, I will often try another and sometimes have success if I have an indication for it. And then for ASCVD risk reduction, we have evidence for semaglutide, both forms, dulaglutide, liraglutide, and we're still waiting on the tirzepatide data. I'm guessing it will show it, but we don't have that full trial released yet. Okay, shifting gears away from GLP-1s into finerenone. So a couple years ago, I presented on finerenone, which is our selective non-steroidal mineralocorticoid receptor antagonist. At that point, it had been approved for the use in adults with CKD and type 2 diabetes. It's now approved for individuals with heart failure with a left ventricular ejection fraction greater than 40%. When I presented previously, I talked about the fidelity analysis. This enrolled, it was 2 different trials that enrolled folks with type 2 diabetes with a really broad spectrum of chronic kidney disease, and they showed a reduction in cardiovascular and kidney outcomes as compared to placebo. And they didn't seem to have any difference whether or not folks were on SGLT2 at baseline or not. So that's kind of where we're starting. As a result, the ADA standards of care recommend the use of finerenone, and it's been in there for several years now to use finerenone or consider finerenone to reduce cardiovascular events in CKD in folks with albuminuria. So what are new trials adding to it? So the first trial I want to look at is finerenone and empagliflozin. So I think it's really important now that we have these additional medications for the use of in CKD with type 2 diabetes to get more information about if the combination is more effective and how to use that combination or when we should use the combination. So this study looked at the combination of finerenone plus an SGLT2 inhibitor. It included just over 800 adults with type 2 diabetes, CKD, and albuminuria who were already on a RAS inhibitor. The mean age was 66 years, just 25% women, 8% Black individuals with a median urinary albumin creatinine ratio of 579. And they randomized individuals to finerenone or empagliflozin or both. And they looked at a surrogate endpoint. I think this is one of the limitations of this study is that it was fairly short, 180 days, and they only looked at the kind of relative change in the urinary albumin creatinine ratio. But I think it's better than nothing. That's why I wanted to present it. So what we saw is that, unsurprisingly, both of our individual agents reduced the urinary albumin creatinine ratio. So we know SGLT2 inhibitors improve that. We know finerenone improves it. And what this study adds is that we saw an even greater reduction with the combination. So a 52% reduction in urinary albumin creatinine ratio after 180 days. So pretty significant reduction. As far as tolerability, unsurprisingly, when we add another medication, we get a little bit more adverse events. So there were slightly more adverse events leading to discontinuation. And then the hyperkalemia results kind of follow what we know about the SGLT2 inhibitors and finerenone, so much higher in the finerenone only arm. Using an SGLT2 inhibitor with finerenone seems to reduce that, but not eliminate the risk of hyperkalemia. So monitoring is really important. And then we do see a more likely to see that drop in EGFR when we start the medication. And we just need more information, longer studies to tell us and kind of show us if that initial drop in EGFR kind of then results in greater kidney protection over time, like we see with the SGLT2 inhibitors. So looking again at those KDIGO guidelines, right now, finerenone is recommended kind of on our second row of options and is recommended if persistent albuminuria and normal potassium after RAS inhibitors, after SGLT2 inhibitors. I'm not sure this evidence is going to change that recommendation, but I do think it strengthens the use of finerenone in combination with our first line options. So I've talked a lot about GLP-1s for CKD, now finerenone for CKD, which leads us to now we have, whereas several years ago we had just our trusty ACE inhibitors or ARBs, now we have 3 more classes that have shown really impressive reductions in cardiovascular outcomes, renal outcomes. However, there's some factors to consider when we're choosing between them. And right now we don't have a lot of guidance to help us, but it comes down to some of these factors in clinical judgment. So some of the factors I consider are costs. These are all really high cost drugs. And so I think it's probably, frankly, unrealistic for a lot of patients to be on all of them. So then we're going to need to choose which one we think we want to prioritize or which 2 we want to prioritize. When I'm thinking about that, I think about EGFR. So the GLP-1 agonist can be used regardless of EGFR. SGLT2s can be used down to an EGFR of 20. And finerenone down to an EGFR of 25. So sometimes that is a factor in our individuals with CKD. Potassium, finerenone can't be used if the potassium is over 4.8. So that could be a factor. These are folks with type 2 diabetes. So A1C lowering desired often factors into mine. I'm obviously a little biased. I think the people I work with the most have really high A1Cs. And so I'm preferentially choosing a GLP-1 a lot of the times because I'm going to get a lot of A1C lowering with that as compared to very little with an SGLT2 and obviously none with finerenone. And then other comorbidities like weight loss, to be honest. If weight loss is going to help other patients' comorbidities, help their quality of life, we're going to get a lot of that with a GLP-1 and not less so with an SGLT2. So all of those factors combined is what I'm taking into account, what I encourage you to take into account when choosing among these. And then, of course, along with cost, probably coverage too. Okay. Shifting gears, staying in finerenone, moving on to HFpEF. This trial came out last year, the Fine Arts Heart Failure Trial. This was a large trial, 6,000 adults with heart failure with an ejection fraction of 40% or greater. The mean age, 72 years, about half women, very underrepresentation of Black individuals. Again, unfortunately, most of these patients were NYHA class 2. And very small percentage here again on the SGLT2 inhibitors or GLP-1 agonists, which is not surprising. All of these trials were going on at the same time these other drugs were being approved, and so they haven't really become standard of care. These individuals were randomized to finerenone or placebo in addition to usual therapy, and they looked at a composite of total worsening heart failure events and death from cardiovascular causes. And what they found was a significantly fewer events and deaths in the finerenone arm. Works out to 14.9 events per 100 patient years in the finerenone arm versus 17.7 per 100 patient years in the placebo arm. When you compare this to the SGLT2 trials, which looked at SGLT2s and HFpEF, pretty similar treatment effects. There was no significant difference in death from cardiovascular causes. So this was really driven by a reduction in those heart failure events. And there was no significant difference in KCCQ or symptom score. So I think this evidence, given that it met its primary endpoint, is really going to strengthen this recommendation for mineralocorticoid receptor antagonists. They're currently listed as a treatment option for HFpEF based on the spironolactone data, but there's a lot of issues with the spironolactone data. It didn't meet its primary outcome, for example. This really strengthens the recommendation for adding a mineralocorticoid receptor antagonist in patients with HFpEF to see that reduction in cardiovascular events, heart failure related events. So to wrap up finerenone, before we'll try to briefly do my last topic, we should consider finerenone for patients with type 2 diabetes and CKD who have persistent albuminuria despite maximally tolerated RAS inhibitor and SGLT2. We should also be considering a finerenone for folks with heart failure with mildly reduced ejection fraction or preserved ejection fraction. Monitoring potassium and considering potassium is very important with finerenone. In this case, you shouldn't expect a significant blood pressure reduction. So a lot of us are used to using spironolactone, a really effective blood pressure lowering medication. Finerenone is not. Pretty modest blood pressure reduction. It also doesn't have any impact or a significant impact on functional status or quality of life for folks with HFpEF. And then, as usual, cost is going to be a barrier. I see these probably most restricted in terms of prior auth as compared to SGLT2s and GLP-1s. You really have to show that they're like on maximal other therapy before insurance will approve of finerenone. Okay, and then I want to leave a little time for questions, so we're going to thankfully do my shortest topic last. So I want to talk about some new evidence regarding and guiding the extended treatment of VTE. So the first trial was a large non-inferiority, multi-center, randomized, open-label blinded endpoint trial. That's a mouthful. This was conducted at 47 hospitals in France. About 2,700 adults who had acute symptomatic VTE who had completed 6 to 24 uninterrupted months of full dose anticoagulation and for whom extended anticoagulation is indicated were randomized in this case. And this is a key point. We have a couple previous trials, the Amplified trial and one other, that looked at reduced dose of DOACs, but in folks who could it was I think of it as like a toss-up whether you're going to continue anticoagulation. This trial included folks who had an indication for extended anticoagulation. So these were folks with a first unprovoked VTE, recurrent VTE, or the presence of persistent risk factors or other clinical situations considered to be a high risk of recurrence. So that's kind of who was in here. Average age 62 years, 35% women. Most of them had a PE as the index event. And most of them, this was their first episode of an unprovoked VTE, is what kind of landed them in this trial. They were randomized to either low dose therapy, either with apixaban or rivaroxaban, or kind of standard dose, high dose therapy with apixaban or rivaroxaban. And they looked at symptomatic recurrent VTE. What they saw was they're really low numbers. I think that's the biggest takeaway, is that the recurrence rates were very low in both groups. The cumulative 5-year incidence was just 2.2% in the low dose group versus 1.8% in the full dose group. This did not meet the non-inferiority criteria, but again, really low numbers. In terms of safety, lower dose was certainly safer. So there was a significant reduction in major or clinically relevant non-major bleeding. And as a result, the net clinical benefit, which adds all that together, favored the low dose group. So the net clinical benefit favored using that low dose group after 6 to 24 months of full dose therapy. So I think the takeaway here is, I think this is encouraging for folks especially at folks who are at high risk of bleeding. We know that the risk of recurrence seems to be pretty low after that kind of first period of full dose treatment, but we certainly are going to need some more research to help clarify who should remain on that full dose versus who can we confidently move to that lower dose. And then finally, the last trial is similar, except with cancer-associated VTE. I thought this one was really interesting because we certainly think that cancer is kind of an ongoing risk factor that really increases their risk of recurrence. In this case, 1,700 adults with active cancer in a proximal DVT or PE who, again, had completed at least 6 months of treatment were randomized to either low-dose apixaban or kind of standard full-dose apixaban. And again, they looked at recurrent VTE over 12 months. In this case, the lower dose did meet the non-inferiority criteria. So pretty similar, slightly lower in the low-dose group, but pretty similar. And again, we saw less clinically relevant non-major bleeding. So really seems to be that if we lower the dose after that initial treatment for extended treatment of VTE, we see a low risk of recurrence, definitely less bleeding. And now we just need probably a more clarification of who needs to stay on that full dose treatment versus it seems like probably many patients would be safe to switch to a lower dose and get that benefit of safety. Okay, I squeaked in with 5 minutes to remain. So happy to answer at least a couple of questions, hopefully.
Great. Thank you, Dr. Fry. I'll pull a question from online here first. Have you seen issues with patients getting non-standard GLP-1 agonists from compounding pharmacies or outside sources? Any issues that you have actively seen?
Yes. And I think probably a lot of people in the room that work inpatient have seen more of them in real time, but I've certainly heard about them. The thing I've seen the most with compounding GLP-1s is folks end up with this like bottle of GLP-1 with no clear instructions on how to use it, and they end up taking these big doses, or I don't even know what they do. So I personally don't feel comfortable recommending a compounding without a lot of shared decision making around it. I will say the best option now, it's still expensive, but the best option now for folks who do not have insurance coverage is to get the tirzepatide or semaglutide direct from the manufacturer, so from Lilly or from Novo. And if you get it direct from them, it's about half price, which half price is still very expensive. It's $500 a month. But if you get it at retail without insurance, it's $1,000 a month or more. So that's my best recommendation when folks don't have insurance coverage. For most people, that's still out of reach, but I feel much better about that safety than compounding. I've just seen too many errors.
Thank you. Any questions here in the room?
I'm not sure it makes a difference, but you said that there was maybe something like a 15% reduction in risk of dementia with strict blood pressure control. Is that a relative risk reduction or an absolute risk reduction?
It's a great question. I believe I usually shy away from relative risk reductions, but I'm pretty sure that's a relative risk reduction. Yeah. So yeah, the absolute risk reduction, pretty small. That said, I think any risk reduction in dementia is probably meaningful, at least to our patients. But yes, it's not this overwhelming absolute risk reduction in dementia. Good call.
I'll ask a question. Thanks for updating us a bit on the PREVENT calculator, which I think many of us saw come out, but weren't sure how to operationalize. Have you seen this in use clinically yet? Is it integrated with Epic? I assume not.
Yeah, probably about a year ago, I asked, frankly, Dr. Rosenberg and Dr. Gluckman. And at that point, because it wasn't in any guidelines, it had not been operationalized into Epic. Maybe Dr. Chow knows more, but I don't think it's been yet. I think it will be coming now that we have it in guidelines. And I certainly like it a lot better in terms of those other risk factors include the fact that it does include race. We know it is more accurate. And so I'm hopeful that it will get incorporated in Epic soon, because I know if it's not an Epic, it's hard to use if you have to go outside and click in all the buttons yourself. It takes too much time.
Well, I think in the interest of time, since we're at 8:59, we'll be sure to end week 1 on time. Thank you, Dr. Fry.